Hello, everybody. I just finished the entirety of NBME 30, and based on my review, I have generated 200 questions that are completely original, which cover all of the topic that I believe you should know at this point in your prep. I'm going to break everything down and explain it super simply. It takes dozens of hours to create all of my original questions, so please consider liking and subscribing. The questions I'm giving you are entirely different, but they cover all of the topics and the concepts that you will need to know in order to pass step 1. In our first question, a 48-year-old man presents to the emergency department with complaints of excessive thirst and frequent urination over the past several weeks. He reports drinking over 5 liters of water daily and urinating frequently, including multiple times in the night. He denies dysuria, which just means painful or difficult urination. He denies hematuria, which is the presence of blood in the urine, or any recent changes in his weight and diet. Physical exam is unremarkable. Lab test show that his plasma level is 148. So a sodium level of 148 is considered high. It's called hypernatremia because typically the normal levels are 135 to 145. So this is a little bit elevated. So there's probably some imbalance, maybe dehydration, excess sodium intake, or some other condition like we'll talk about soon. And a water deprivation test is conducted and it shows no significant increase in urine osmolality. And osmolality is just a fancy way of saying the concentration of a solution. And subsequent administration of desmopressin results in a marked increase in urine osmolality. A brain MRI reveals a mass in the hypothalamic region. Which hypothalamic nucleus is most likely affected? By the way, I have timestamped everything so you guys can skip to the questions you'd like. But what we need to know for this one is central diabetes insipidus and also what the supraoptic nucleus of the hypothalamus does. So I like to call this condition the thirsty brain, leaky bladder. And what we need to know is that the supraoptic nucleus in the hypothalamus synthesizes ADH, which is vasopressin, and that is critical for water retention. And if you get a lesion that affects that area of your brain, that leads to what we call central diabetes insipidus. And that is characterized by dilute urine and high plasma sodium. Because if ADH is critical for water retention and you don't have it anymore, then you won't get water retention. Instead, the water will go out, and that's why the urine is dilute. Basically, we have to understand the hypothalamic anatomy and function to answer this question, especially what's called osmoregulation. Okay, so the paraventricular and the supraoptic nuclei of the hypothalamus, they produce the hormones that are transported to the posterior pituitary. All right, and what are those hormones? We mentioned one of them. It is ADH, and what's another one? Oxytocin. And ADH, we said, plays a critical role in concentrating the urine by increasing water reabsorption. Where? In the collecting ducts. And when there's a deficiency of ADH, as in central diabetes insipidus, then the patients will present with polyuria and polydipsia. Polyuria, fancy word for the production of abnormally large volumes of dilute urine. And polydipsia is a great thirst. And that's a symptom typically of diabetes or some sort of a physiological disturbance. Like they could be feeling like they were prompted by spirits to drink a lot of water or to cleanse them, is how I've seen that tested. But this leads to hypernatremia because all of that water is gone. And so what's left is that sodium. And that's why it was elevated at 148 in this question. Now, a water deprivation test is the gold standard for this condition. Because if the urine osmolality, the urine concentration, does not rise with dehydration, but it does rise after you give them a medication called desmopressin, that points to central diabetes insipidus versus nephrogenic. Because in nephrogenic, desmopressin has no effect. And I'll explain that in a second. If you're feeling a little bit confused, don't worry, this is all going to make complete sense. But the buzzwords for this question are going to be excessive thirst, frequent urination. That's the hallmark of diabetes insipidus, and you have an osmotic imbalance. The plasma sodium level of 148 is a giveaway that there's mild hypernatremia, and that's due to the free water loss. And water deprivation leads to no change. That tells us that there's an ADH issue. So it's either central or nephrogenic. But then desmopressin shows a marked increase in the urine osmolality. So that means what we're dealing with is central DI. The brain is unable to produce the ADH. We've also been told that there's a hypothalamic mass, and that means there's probably a direct lesion in the nuclei that produces ADH. And we have to know what that is, and the answer is the supraoptic. Now, I made a song. It's called 10 Hats on Deck, where I go over all of these, flat peg mnemonics. The channel was split. 50% of you guys were like, I love it, and 50% of you guys were like, I don't love it. So I think I'll start to include some songs because honestly, you can get a lot of points just by remembering some really cool high-yield facts. But I told you I would talk a little bit about desmopressin, so I'm going to do that now. The pathophysiology is that we have the hypothalamic lesion in our supraoptic nucleus. Okay, so we got a lesion there. That decreases the ADH. Hopefully that makes sense. Next, because of that decreased ADH, the collecting ducts are impermeable to water. And so you get large volumes, and I'll draw this in blue, of water loss, right? That water is being lost because of this. The ADH is not there. And so the water loss begins to exceed the intake, and that leads to increased serum osmolality, increased sodium. And so what we do for desmopressin is first we have to understand, what is desmopressin? Is that when you press buttons on Desmo? Which is what I love to do in high school. Friggin' Desmos is the best calculator program online. I digress. But desmopressin is an ADH analog. And so it actually bypasses that brain defect and it binds directly to these VT receptors in the kidney, and that increases water absorption. And it's like, yay, you got a good time. You can finally increase the urine osmolality. Cool. So I feel like we explained that. If I just zoom out right here, I think we explained that pretty well. That's everything we need to know for this question, but it's also important to know other potential answers that they could have given you. Because what if they didn't focus on this condition at all? What about the arcuate? Well, that is related to dopamine, if you had a lesion there. And as you know, dopamine, that inhibits prolactin. Obviously, that's wrong because it has nothing to do with ADH. Okay, what about the ventromedial? Well, that's the satiety center. And so a lesion there would cause hyperphagia. But what I want you to remember is this phrase: ventromedial lesions make you massive. So it's related to appetite, not water balance or ADH. And that also came from one of my songs. Another answer they could give you is the dorsomedial. And if that's lesions, that leads to aggression. And for that, I like to think of two things: a shark, because I think of their dorsal fin, they're like a menacing, angry thing. They're actually not. They're calm creatures, but it just helps to associate dorsomedial lesions with aggression. Also, if you're aggressive, I think you're a dork. And so dork medial aggression. Okay, just a little way to help remember. Anything works. Lateral. By the way, I really recommend making your own mnemonics. It really helps. Now, this is the hunger center. And so a lesion would lead to, can't say this condition on YouTube. And apparently I can't spell it either, but that is the condition, not eating. And that is appetite related. It's unrelated to the thirst and the ADH here. All right, so somebody who's been guzzling water and peeing like crazy, labs show hypernatremia. So he's losing more water than sodium. And a water deprivation test is not going to help, but you give desmopressin, and finally, boom, it's concentrated, it's central diabetes insipidus. So what's broken is the hypothalamus has a supraoptic nucleus that produces ADH. So if you see polydipsia, polyuria, high sodium, in response to desmopressin, then think of the supraoptic. Think of central DI and just lock that in. All right, and this next question, oh my gosh, I just realized rain sounds have been on this whole time. You know what? I'm not going to turn off the rain sounds. Hey, Alexa, volume 1. There we go. Hopefully you guys can imagine the nice rain sounds with me. I love the rain. It calms me. Which, by the way, what causes the calming effect? Parasympathetics, right? Maybe your vagus nerve, acetylcholine transmit, slows your heart rate via the SA node in the heart. Bronchoconstriction, slower breathing in the lungs, GI tract, increased motility secretion. You feel calm. That's how I feel right now with the rain. And when I turn it off, I activate the HPA axis, right? But stress activates that axis and you get cortisol release from the adrenal cortex. So calming activities like listening to the nice rain sounds can reduce CRH, ACTH, and cortisol levels. Less cortisol means lower anxiety, better sleep, and improved emotional regulation. But I digress. In our next question, we have a 3-month-old infant brought to the pediatrician by his parents due to concerns regarding a light brown patch on his back. You can see there in the image, it's kind of funny, that little AI-generated image there. The patch has been present since birth and is approximately 2 centimeters in diameter and smooth, well-defined borders. The infant's development has been normal, and there are no significant findings on physical exam other than the described patch. Family history is non-contributory. Which of the following is the most likely nature of the skin lesion? Okay, so we have to distinguish if this is benign, what type of skin lesion is this. We got to recognize the color, the shape, and the number, and that's why I've drawn this out here in my beautiful brown. And this person has a solitary, smooth-bordered tan macule present since birth, and there's no other symptoms. And this is most consistent with Cafe-au-lait. It's typically benign unless you find multiple. So the light brown patch is Cafe-au-lait, which is like coffee with milk. Well-defined borders. Smooth, kind of looks like the coast of California versus the coast of Maine, which is McCune-Albright. There you can kind of see the difference. And this is associated with neurofibromatosis type 1. And the reason I wrote hypo versus hyper is that Cafe-au-lait is actually hyperpigmented, right? So that's why they say Cafe-au-lait is coffee with milk, right? And so coffee is not hypopigmented, it's tan to light brown, but it can be darker depending on the skin tone. And the pigment source here is the brown color comes from the increased melanin in the basal epidermis not from hemorrhaging like in bruises, and it's not hypopigmented. Because if it were hypopigmented, that'd be something like an ash leaf spot, right? So hypopigment would be like an ash leaf. And that's seen in tuberous sclerosis, which is lighter than the surrounding skin. All right. And tuberous sclerosis is a condition that causes benign tumors to grow in the brain or other vital organs. And so our answer for this question is Cafe-au-lait macule. You can tell because of the way it is. Light brown, sharply bordered, classic. Unlike melanocyte nevi, which lacks hair, unlike vascular, they are not red and raised, and a bruise would change the color and resolve. Okay, so well-defined light brown patch in infant is most likely Cafe-au-lait macule. All right, and our next question, we have a newborn girl evaluated for oligohydramnios-related complications and is found to have Potter sequence. Ultrasound imaging confirms the absence of both kidneys. Genetic analysis shows no chromosomal abnormalities, and the kidney abnormality observed in this patient most likely derived from a failure of which of the following embryonic structures to properly develop. And we got a lot of ducks here. So this question is asking about Potter sequence and its bilateral renal agenesis that causes pulmonary hyperplasia, limb deformities, and a flat face due to oligohydramnios. And this is due to the failure of the metanephric blastema to develop or the failure of the uteric bud to induce it. Uteric bud, and what you remember here is that there is reciprocal induction between these two. Basically, the permanent kidney develops from two embryonic structures. There's the uteric bud, and that is from the mesonephric duct. That becomes the collecting system, right? The collecting duct, the calyces, the pelvis, the ureter, and the metanephric mesenchyme, which is the blastema, that becomes the nephron structures, like the glomeruli, the PCT, the loop of Henle, and the DCT. So uteric, it ends in ic, so it collects, ic, collect, and then I think of urine, so collects the urine. And the meta is when you're getting to meta, right? You're getting into the actual structures, so it's the actual glomeruli, the PCT, loop of Henle, etc. And those two have to interact for normal kidney formation, and if either of them fail, then you get agenesis. And bilateral renal agenesis is what Potter sequence is. So if there's a failure to the uteric bud to develop or induce, then you get no kidneys, and the metanephric blastema is the tissue that differentiates into the functional nephrons. So unilateral agenesis is asymptomatic, but bilateral would be fatal after birth. You get respiratory failure due to pulmonary hypoplasia. And I'll talk about that in a second, but I want to cover some of the other answers like mesonephric. Well, that becomes the male reproductive structures. You can remember the mesonephric because it has an S in it, so you can think of sex. Because it becomes the epididymis, the vas deferens, and it gives rise to the uteric bud, but the kidneys themselves, the nephrons, come from the metanephric blastema. How about the Mullerian duct? Well, that's the female reproductive tract. That involves the fallopian tubes, uterus, upper vagina, and that's related to kidney formation. What about the para-mesonephric duct? Well, that's another name for the Mullerian duct. It's the same as above. And what about the pronephric duct? That's early non-functional kidney precursor, and it degenerates pretty quickly. Now, I mentioned I talk about pulmonary hypoplasia, and so in bilateral renal agenesis, both the kidneys fail to develop. And that means the fetus can't produce urine. And so urine is the main source of the amniotic fluid after the first trimester. And of course, the first trimester is just that initial stage of pregnancy, spanning from conception to week 12. That's where you have the implantation in the uterus. The major organs and systems like the brain, spinal cord, and the heart and digestive tract start to form, and the limbs start to develop. And the fetus is about 3.5 inches long and weighs about 1 ounce. A lot of changes in the mom occur as well. The uterus expands, blood volume increases to support the baby, and the immune system adjusts to protect the mom and the fetus. And there's really a chain breakdown here. That's why it's, Potter's sequence. It starts out with no kidneys. No kidneys. Reminds me of a Studio C sketch. And no kidneys means no fetal urine. No fetal urine means low amniotic fluid. If you give a mouse a cookie, low amniotic fluid leads to fetal compression. You don't have that buffer anymore. There's no cushioning. And so you get the flattened face and the limb deformities and the clubbed feet. And so there's also no amniotic fluid to breathe, right? And so the lungs can't expand. And that leads to pulmonary hypoplasia. You get severe respiratory failure at birth. And that's the Potter's acronym for you. P stands for pulmonary hypoplasia. O is for oligohydramnios. T is for twisted face. T is for twisted limbs. E is for extremity defects. And R is for renal agenesis. And we might see another question on that soon. But bilateral renal agenesis means no urine, oligohydramnios, no lung development, and the baby can't breathe, and it's fatal. Okay, and in the last video, I explained some really cool pearls from evolutionary biology, and this is a fascinating one. And you might have thought it's kind of weird that humans go through 3 systems during development. right? Like why, and you have to know this for step one, like this is super relevant. Like why do we have the pronephros and the mesonephros and the metanephros? Because the pronephros is around 4 weeks. And this, interestingly enough, actually resembles the primitive fish. I know this because one of my professors of nephrology at Harvard was the foremost like expert in ichthyology, like biological representations. And he has a paper in Nature where he talked about how fish resemble like the pronephros in humans. And so the fate of this pronephros is a non-functional regress. But then the mesonephros, that's around like weeks like 4 to 8, that resembles amphibians and fish. And there's like a temporary kidney which forms the Wolffian mesonephric duct. This is where it gets interesting. The metanephros, that's the week 5 and onward. It's like our third attempt. And that resembles mammals. And that becomes the permanent kidney. And so there's literally, you can see in the progression, the embryonic kidney evolves in a fish-like sequence. And so what's crazy is our mesonephric duct, like the Wolffian duct, right? That ends up carrying the urine and the sperm in fish, but in humans, it becomes the vas deferens. And the paramesonephric duct, the Mullerian, is not present in fish, but it becomes the fallopian tube and the uterus and the upper vagina in humans. And so in males, the Wolffian duct survives, and in females, it regresses, and the Mullerian duct becomes the reproductive tract. And the interesting thing is our genital plumbing evolved from fish kidneys. So nature is just reusing the same embryonic tubing for both pee and reproduction, right? Have you ever asked yourself, like, wait, why do those things co-occur? It's because we evolved from fish and we repurposed the fish kidney ducts to do sexual reproduction. And this is just fascinating. The liver, the gonads, they're ancient vertebrate organs, but the urinary and the reproductive ducts, like the vas deferens, urethra, fallopian tubes, those evolve from structures that are shared with the excretory systems in fish. Okay, last thing, because it's kind of relevant for step 1, is that descension pathway. Because in fish, the gonads actually stay near the dorsal body wall, but in mammals, the testes have to descend into the scrotum. So you see that same kind of morphology being loaded and adapted to in mammals that is present in fish. The testes descend into the scrotum. And why? Temperature regulation. But they start near where? Where do they start, everybody? The kidneys. That's right. And that is why testicular arteries come from the abdominal aorta. It's because of your fish ancestry. Insane, right? Hopefully you guys like those evolutionary biology pearls. That way my degree doesn't go to waste. And so the absence of kidneys in Potter sequence indicates failure of the metanephric blastoma development. Okay, and our next question. Let me load these images for you. There we go. A 62-year-old woman presents to the emergency department with shortness of breath and generalized weakness. Her medical history is significant for poorly controlled hypertension in the past 5 years due to non-adherence to medication. On examination, her blood pressure is 240/120. Laboratory tests reveal elevated blood urea nitrogen and creatinine levels. She is admitted for further management, but unfortunately suffers a cardiac arrest and passes away. During autopsy, which of the following histological examinations is most likely observed in her renal? Okay, so we need to kind of define some terms. And the first one is malignant hypertension. That's where you have 180/120, and that can cause hyperplastic atherosclerosis. And atherosclerosis, I know you've heard it a million times, but that's where the small arteries, the arterioles, become thickened and narrowed. So thick and narrow, and that narrowing reduces the blood flow to the organs and the tissues, and that can lead to, various health problems. It's caused by high blood pressure, by diabetes, high cholesterol, smoking, and even your age. And there's some types here. There's hyaline atherosclerosis, and that's where you have the deposition of hyaline in the walls of the arterioles. And then there's hyperplastic atherosclerosis, and that involves the proliferation of in the walls of the arterioles, and that leads to thickening. All right. Now, sudden end organ damage, especially the kidneys and the brain and the heart, is the hallmark of hypertensive emergencies. And so we know they have a hypertensive emergency. They got a blood pressure of like insanely high, 240/120, and elevated BUN and creatinine. That's just an acute kidney injury as well. And they're going to die due to that end organ failure. And then we examine what happened. Now, the pathophysiology is very important. And so what happens is you have severe long-standing hypertension, and that leads to smooth muscle hyperplasia in the arterioles. They're like, okay, we got to get used to this. And that's what looks like onion skin, and it's the concentric layering of the arterial walls, the hyperplastic atherosclerosis. They're preparing. They're undergoing hyperplasia. And so we see a decrease as well in the lumen size. And you get ischemia to the glomeruli and the tubules, and that lack of oxygen causes acute kidney injury. And if it's super severe, you can also see fibrinoid necrosis. So the key associations for boards are onion lesion skin, that's malignant hypertension, and also the elevated BUN and creatinine tells us that there's renal damage, and there's an organ signs as well. So you might see some CNS and some heart involvement and some kidney involvement as well. And hyperplastic atherosclerosis is a concentric laminar thickening of the arterioles. So our answer is going to be our beautiful onion skin appearance. It's the concentric layering of smooth muscle, all over the basement membrane. And that looks like an onion skin. All right, what about tubular atrophy? Well, that's seen in chronic ischemia kidney disease, not specific to malignant hypertension. That's wrong because she had acute presentation. It's not necessarily going to be chronic damage. How about fibrinoid necrosis? Well, that is seen in the acute phase of malignant hypertension, especially when there's a vascular rupture, and that's possible, but onion skin is more consistent with long-standing malignant hypertension. What about hyaline atherosclerosis? That is benign hypertension or diabetes related, and so there's going to be protein leakage into the vessel wall. That's not malignant. And then glomerulonephritis, that's an immune complex-mediated hematuria or red blood cell cast condition. That's wrong because there's no signs of glomerular inflammation or nephritic syndrome. So if you got 240 over 120, then literally what's happening is you're shredding your organs from the inside. And the arterial wall is thickening in concentric layers and narrowing the lumen and starving the tissue, and it leads to organ failure. Now, hyaline changes is a little bit too mild for this. Fibrinoid necrosis is possible, but it's more acute, and tubular atrophy takes time, and glomerulonephritis is not an immune process. All right, so why is this not amyloidosis? That's like the most common question I hear. Okay, so first of all, the timeline for amyloidosis would be chronic, slow onset, whereas this patient is much more acute and sudden onset. Next, amyloidosis usually has like a normal or mild hypertension, but here it's severe malignant hypertension. Also, the kidney signs for amyloidosis, you'd have a nephrotic syndrome. There's massive proteinuria and hypoalbuminemia, but here there's no mention of proteinuria. Also, the histology looks different for amyloid. You have Congo red deposits and apple green bifringence on polarized light. And here we just have the onion skin atherosclerosis, not deposits. And the organs involved for amyloidosis are the kidneys, the heart, and restrictive cardiomyopathy in the GI and the nerves. But here it's only renal, blood pressure related, and organ damage. And so it's just more gradual with amyloid, and it leads to chronic renal insufficiency. Whereas this condition is acute hypertensive crisis with cardiac arrest. And that's the reason it's not amyloidosis. The blood pressure would be lower, histology would be different, the syndrome would be nephrotic, and you'd have protein deposition. So hyaline is seen with benign chronic hypertension, pink vessel walls. Hyperplastic is malignant hypertension, that's the onion skin stuff. Amyloid would be a protein deposition stuff, that's the Congo red, nephrotic stuff. And papillary necrosis is the infarctic tips of the nephrons that's caused by toxic and ischemic injury. So the onion skin and the renal arteries tells us there's severe hypertension-related changes. All right, in our next question, we have a 30-year-old woman presenting to the clinic with a one-day history of sudden onset abdominal pain described as crampy and diffuse, accompanied by nausea and intermittent vomiting. She reports chronic episodes of dark-colored stools over the past several months, and on physical examination, her abdomen is mildly distended with hyperactive bowel sounds. And she has numerous freckles on her lips, oral mucosa, hands, and feet. Her hemoglobin level is 10.5, mean corpuscular volume is 70. Abdominal ultrasound reveals dilated loops of the small bowel with evidence of target signs. Which of the following is the most likely diagnosis? All right, let's talk about this condition here. The first one on this list, Peutz-Jeghers syndrome. The most important facts for this one is that you have mucocutaneous pigmentation. That's the freckles on the lips, the mouth, the hands, the feet. Also GI polyps. Polyps, you should think the P in the Peutz-Jeghers. And the complication is small bowel intussusception, especially in young adults. And you also have that target sound. Okay, so that's the really buzzy kind of thing to remember with this condition. They're tying together the genetics, the GI symptoms, and the surgical emergency, which is the intussusception. And intussusception is just the inversion of one portion of the intestine into another one. And so you're given an acute abdomen, chronic blood loss anemia, mucocutaneous freckles, and a target sign on imaging, and all of that points to Peutz-Jeghers. So the way this will look is you'll have little freckles on the lips and also some oral mucosa, the mucocutaneous macules. You can see some crampy abdominal pain and vomiting, and the target signs on ultrasound. So they got a little bit of GI symptoms. Maybe they have some risk for things like cancer and breast or gynecological, like ovarian, cervical, or uterine cancer, intussusception. And the way that this happens, by the way, is you have an STK11 mutation. You get impaired cell cycle control. That leads to the development of hematomatous polyps. That's the non-neoplastic, but they're super bulky. And then the polyps act as lead points for intussusception. And then you get a chronic polyp bleeding. and that leads to iron deficiency. And then you have an increased risk of multiple malignancies. So watch out for those lips, oral mucosa, and the fingers, mucocutaneous macules, the polyps in the small bowel. By the way, a polyp is just this small growth that's usually benign. Iron deficiency anemia, intussusception, and usually this presents before the age of 40. All right, so here's an explanation, and here are all of the other answers, like von Hippel-Lindau. That would be seen with hemangioblastomas, renal cell carcinoma, pheochromocytoma, no neural tumors. For this one, you'd see telangiectasias. Charcot syndrome, that's associated with FAP and Lynch, brain tumors. And FAP, thousands of colorectal adenomas. And that's not what we see here. So basically, the freckles on your lips can tell you that you've got an emergency. You'll do an ultrasound, you see a target sign, intussusception. And usually the freckles on the face will be paired with chronic dark stools for anemia. And it's because of this autosomal dominant condition with that STK11 gene that we talked about, leading to hematomatous polyps. And hematomatous just means that the tissues are made from the same site where it grows, but it's just kind of disorganized and structurally different from the normal tissue, but it's like the same kind of stuff. And intussusception hurts, by the way. So the bottom line is Peutz-Jeghers syndrome presents with abdominal pain, anemia, and mucocutaneous pigmentation due to intestinal polyp. All right, so next we have a 28-year-old construction worker presented to the clinic with pain and weakness in his right arm after trying to lift a heavy beam. He reports difficulty lifting objects and feels a popping sensation at the same time of the injury. On examination, there is swelling and tenderness over the anterior aspect of the upper arm and a noticeable bulge in the midarm where he tries to flex the elbow. No sensory deficits are noted. When asked to supinate the forearm against resistance, the strength is significantly reduced compared to the other arm. Which of the following nerves is most likely damaged in this patient? All right, so he's got some Popeye's deformity, right? The biceps tendon rupture. And that causes a weakness in the forearm supination and elbow flexion. And that's the function of the biceps brachii. And the biceps brachii is innervated by the musculocutaneous nerve in the C5, C7. Right, that's literally this muscle right here. Okay, so it's not the axillary, because that'd be like the deltoid teres minor shoulder abduction. That's wrong because no shoulder weakness is present. It's not the radial, because those are the extensors of the wrist and the fingers. You have posterior arm sensation as well. There's no posterior sensory loss here. It's not the median. That'd be associated with the forearm pronators and also the thenar muscles. There's no pronation or thenar weakness here. And it's not the ulnar, because that would be the intrinsic hand muscles and claw hand. So this dude is lifting a heavy beam and he hears a pop, and we just get a bulge, and it's going to be the Popeye deformity, the biceps tendon rupture. That's the most powerful supinator in the forearm, and its nerve supply is that C5 to C7 root. And so injury there produces that weakness in supination and elbow flexion. And this is what people like to flex when they're all like, oh, look at me. So musculocutaneous nerve is the answer. And I really quickly just wanted to break down the median and the radial as well, these nerves. So the median nerves, these are associated with C5 to T1. The radial is also C5 to T1, so what gives? Well, the radial comes from the posterior cord of the brachial plexus, and the median comes from the medial and lateral cords of the brachial plexus, and the functions are different. So the radial, you have extension of the elbow and the wrist and the fingers, and also supination of the triceps. Okay, so that's the radial, and then the main function of the median is the flexion of the wrist and the fingers and the thumb opposition, and also forearm pronation. In the hand muscles, the median does the thenar muscles, that's thumb opposition and also abduction and flexion. And all the motor ends before the wrist in the radial. But the radial, you'd see a damage in the Sunday night palsy, the midshaft humerus fracture. And the median would be like a supracondylar humerus fracture, carpal tunnel, wrist laceration, that kind of stuff. Radial is wrist drop, weakness in elbow extension, and then thenar atrophy, ape hand would be seen with the median. All right, and our next practice question. We've got a 32-year-old male chef visiting the emergency department with a 2-hour history of vomiting, abdominal cramps, and watery diarrhea. He was consuming a homemade meal of chicken salad, don't want to go to his restaurant, 18 hours before the onset. Physical examination reveals mild dehydration but no fever, and a stool sample culture is positive for Salmonella species. He is given oral rehydration therapy and observes an improvement in his condition for the next 48 hours, assuming he receives a course of antibiotics. Which of the following is most likely the outcome? By the way, if you want my extension here, I made a Chrome extension where you right-click and you can actually just search this in Sketchy Medical. So I can just search and click. And of course, you have to have a Sketchy account for this to work. But then you can just go to that video and you can watch it. But if you want that, it's on the web store, which you can access with the link in the description or on the description of the YouTube channel. He's given oral rehydration therapy and observes an improvement in his condition for the next 48 hours, assuming he receives a Course of antibiotics, which of the following is the most likely outcome related to Salmonella infection? Obviously, we have to know a bit about Salmonella. So let's start with the pathophysiology. What happens is you ingest this, right? Bacteria then reaches the ileum, colon, right? Bacteria's arrived, and then it invades the M cells in what's known as these Peyer patches, and that triggers inflammation. And then that causes watery diarrhea via inflammatory cytokines. And then the host immune system usually clears it within 3 to 7 days. And then antibiotics disrupt the microbia, and that reduces the competition, and then Salmonella stays longer in the gut. Okay, so basically you have a recent egg or chicken meal, and you get watery diarrhea, there's no blood, no fever, and this improves with fluids alone, and antibiotics would cause longer shedding. And so you don't give unless there's high risk, like neonates or sickle cell, or the elderly or the immunocompromised. Okay, and so our answer is D, prolonged period of asymptomatic fecal organism excretion. That's what happens if you receive a course of antibiotics. Prolonged period. Because in healthy adults, non-typhoidal Salmonella is self-limited. And so antibiotics are generally avoided. If you give them, then it'll disrupt the gut microbiota, and it allows the bacteria to persist longer. And that leads to prolonged asymptomatic fecal shedding. And there's also the increased risk of transmission, so don't give the antibiotics in this particular case. Okay, what about reduced chance of Guillain? Well, Guillain-Barré would be associated with Campylobacter jejuni and not Salmonella, and that causes Guillain-Barré syndrome. So, nothing associated there. Increased likelihood of developing chronic intestinal complications. Well, that's wrong because antibiotics don't increase chronic GI disease. They actually just prolong the shedding, not causing chronicity. What about prevention of potential Salmonella-associated arthritis? Okay, well, for that one, they're thinking of reactive arthritis, like Reader syndrome, and that can occur despite antibiotics, especially in HLA-B27 subtype patients, and antibiotics are not going to prevent that. So this is a weird question because if you give antibiotics for food poisoning, it can actually make you spread the germs even longer. Okay, there's the breakdown. Antibiotics and Salmonella infections can prolong asymptomatic fecal excretion of the organism. All right, here we have a 70-year-old woman presenting to a clinic with a 4-month history of fatigue, unintentional weight loss, and swelling in her legs. She has a history of carpal tunnel syndrome, and she takes medication for hypertension, but has no other known chronic conditions. On physical examination, she has bilateral pitting edema of her lower extremities. Lab tests show elevated creatinine and hypoalbuminemia. An abdominal fat pad biopsy is performed, revealing amorphous eosinophilic material that shows apple green boots with the fur bifringence when viewed under polarized light on Congo red staining. Which of the following is the most likely precursor of the proteinaceous material found in this patient? I love that adjective, proteinaceous. Containing protein, bodacious, proteinaceous, beater. All right, so what is it? Holy cow. We have to know that this person has a particular type. They have AL amyloidosis. And you're like, okay, what? That makes no sense. No worry, this is going to make sense in 5 minutes. They've got nephrotic syndrome, carpal tunnel syndrome, and Congo red positive amyloid deposits, right? So the most common precursor protein in AL amyloidosis is the, wait for it, lambda light chain. Bing, 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 bing. That is derived from a plasma cell dyscrasia, like, for instance, multiple myeloma. What about all these ones, like apolipoprotein A1? Well, that's wrong because it's seen in very rare hereditary amyloidosis, not typical systemic AL amyloid in elderly. And one important thing to clarify about amyloid is that it's a structural conformation, not a specific protein, right? So amyloid is a beta-pleated sheet structure, and multiple diseases lead to this amyloid. But the precursor protein will vary for each one. And so all of these types form insoluble fibrils with a beta-pleated sheet structure. These sheets stain with Congo red and glow apple green under polarized light. And so you might be really tempted to just say, hey, the answer is E, beta microglobulin, because that can form amyloid. That's true, but it's not the most likely type in this patient, right? So they have a history of hematologic malignancy. They have multiple myeloma risk. There's also cardiac diastolic dysfunction and myocyte degeneration and amyloid on biopsy. All of this fits the AL amyloidosis. And if you weren't sure about what AL amyloidosis was, no worries, I got you. This is our primary type with our lamma and kappa light chains. And the clues here are multiple myeloma and systemic involvement like the heart, the kidney, the tongue, the nerves. And then there's this secondary type, A, and that one is caused by the serum amyloid A, and that's associated with chronic inflammation, rheumatoid arthritis, that kind of stuff. And it's kidney focused, right? The serum amyloid AA, the secondary stuff is really kidney focused. not like this primary stuff, which is the question that we have at hand. I'll screw that up so we can see it. There's also the ATTR transthyretin, and that's hereditary and restrictive cardiomyopathy associated. And there's dialysis related, that's the beta-2 microglobulin in the joints and the bones. And then there's the alpha-beta protein in the brain plaques, that's like Alzheimer's. So there are a lot of these different conditions that leads to the amyloid structure. So first you ask, where is the amyloid deposited? And then you ask, what condition would cause the amyloid there? And then you choose the correct precursor protein, right? So that this is not as easy of a question as you might think. You see beta-pleated, you're like, oh my gosh, pick that. You see the word amyloid, you're like, oh my gosh, pick that. No, not that easy, right? So in this particular patient, we have a kidney and a heart involvement. Kidney, heart. And so we're thinking, okay, this is a plasma cell disorder. So this is AL, amyloidosis, our primary problem. And the precursor is lambda light chains for that. And that's how you get to the answer. So yeah, I wish this were more simple and also honestly relevant, but here we go. We got to solve it. We're paying tuition for this. All right, so yes, the plasma cells produce these light chains, misfolding, plated sheets, the fibrils in the kidneys, the heart nerves, and the GI tract. That was the super important part. Heart, GI tract, tongue, liver, kidneys, all that good stuff. Beta microglobulin is in the joints. Transthyretin would be a lot of family history. Carpal tunnel tells you systemic amyloidosis. There's renal involvement. Serum-free light chain assay. There we go, folks. Bottom line is apple green, boots with the fur on Congo red. Staining indicates amyloidosis, likely due to lambda light chains in this patient. If you're liking this so far, then please like and subscribe. If not, let me know how I can improve. All right, for this next question, I just want to talk about power and significance real quick, and type 1 and type 2 errors. And the best way to memorize this is there's a funny one, and that's 1. And there's a less funny one, that's 2. Just know that the funny one is 1, and then remember that you're telling a guy that he's pregnant, right? He's obviously not pregnant, but you're telling him is. That is a type 1 error associated with your alpha, and a type 2 error associated with your beta is failing to detect an effect that actually exists, right? The effect is that she's pregnant and you're saying it doesn't exist. You're saying you ain't pregnant. Whereas this one, you're saying you is pregnant. All right, so power is 1 minus beta, and that's the probability of correctly rejecting the null hypothesis when it's false. The alpha, or the significance level, is the probability of rejecting the null when it's true. So alpha is the probability of a type 1 error, and your beta is the probability of rejecting, or rather failing to reject, the null when it's false. And the power is 1 minus the beta. So if a medication has no actual effect, the null hypothesis is true. And the only way to find this is through a type 1 error. When you say you're pregnant, but they're actually not. That would be the type 1 error that you find the effect even though there was none. All right, so buzzword, significant level of 5% would be the alpha. That's the chance of finding a false positive. And then the power, 90%, means the beta is 10%, so the actual chance of a false negative. So a type 1 error is a false positive, and a type 2 error is a false negative. And the power is 1 minus beta. So if the power is like 80, there's a 20% probability of failing to detect an effect when it actually exists. And there's an 80% probability of correctly rejecting the null hypothesis when it's false. Anyways, these can be tricky sometimes, so just make sure that we got the 1 and the 2 straight. Good thing 2 is in the alphabet. Alpha goes first, beta is second. 1 goes first, 2 is second. 1 is the funny one. You're pregnant to a man. You ain't pregnant to a woman is 2. Remember, in both scenarios, they're getting it wrong. All right, there you go. There's the super simple framework. Time to go on to our next topic. All right, here's a good question. 86-year-old man presents to primary care physician with a history of recurrent dark purple patches on his forearms, which his daughter-nets have appeared intermittently over the past several years. Patient claims these patches develop without any preceding trauma. He denies any bruising elsewhere. Medical history is significant only for hypertension, for which he takes lisinopril. The forearms have multiple non-tender purpuric lesions over the sun-exposed areas with no swelling or warmth. Review of systems and complete blood count are unremarkable. Which of the following is most likely the cause of his condition? All right, before we dive into this answer, I just want to break down the key features. Elderly patient, forearms, sun-exposed, non-tender purple patches, normal CBD, normal coagulation, skin is thin and atrophic, and there's no systemic disease. And this is a condition that's often confused with ITP or vasculitis, but no systemic features. All right, so we got the chronic sun exposure and the age-related collagen loss, which then will lead to fragile blood vessels. And that fragile blood vesseling leads to senile purpura. And that appears as non-tender dark purple ecchymosis. And ecchymosis is just the discoloration of the skin that results from the bleeding underneath that's typically caused by bruising. So an elderly man presents with recurrent non-tender purple patches on sun-exposed skin, specifically the forearms. And so there's no trauma, no systemic symptoms, no other sites are infected. There's normal CBC, and there are no signs of vasculitis or infection. And so this is going to be actinic purpura or senile purpura, and that's from age-related dermal collagen atrophy. And you have fragile vessels that rupture easily, even without trauma. I've actually seen this in a patient before. They're like, I wasn't even doing anything, and I just got this. And it's right there on their forearm. So that no trauma, the non-tender, no swelling, no warmth, all that is just saying, hey, there's a dermal collagen support problem, and that's why our answer is indeed C. It's just aging and UV exposure. The collagen breaks down over time, and you get loss of the paravascular support, and the capillaries rupture with minor friction. I don't understand how elderly people don't invest in science, or if you're like 50 years old, like there's a real chance that in the next 30, 40 years, we have some amazing breakthroughs, which further anti-senescent technology and allow us to not have these conditions. And if you're not supporting education systems, higher education, grant funding, you're going to die. You're funding your own death, or rather not funding your own death. Just grinds my gears. Sometimes I think like if I were in charge, we would already be on renewable energy and we would have already made so much more progress in the sciences. Makes me mad. So blood leaks into the dermis, right? You get ecchymosis without trauma and there's no inflammation or platelet issue. And this is a non-inflammatory mechanical deficit. That's pretty cool. Non-inflammatory. All right, what about all these trap answers though, right? We know that this is dermal collagen loss from the sun and UV damage and just being old. And we know that this is just the damaged fragile vessel stuff, right? But why is it not ITP? And everybody thinks this is ITP. The buzzwords there are like mucosal bleeding, petechiae, low platelets. Well, that's wrong because the labs are normal and the bruising is localized. That's the reason why it's wrong. It's not vitamin C deficiency, because that would be like a poor diet, corkscrew hairs, bleeding gums, you know, the signs. There's no signs of scurvy there. What about systemic vasculitis, like palpable purpura and systemic illness and elevated inflammatory markers? Well, these lesions are non-inflammatory and there are no systemic findings, so nope. How about medication-induced skin changes? Well, that could cause rashes or photosensitivity, but that's wrong because lisinopril is not an offender of that. This is a chronic issue that's unrelated to the medications. And onto that whole ITP thing, the pathophysiology of ITP is when you have autoantibodies against your platelet antigens. For example, I'm going to zoom this up so you can see, GP2B3A, and that leads to the destruction of the platelets in the spleen. And that can be primary, which is idiopathic, or it can be secondary, which is like after a viral illness or like HIV or lupus or something like that, maybe a CLL. And the buzzwords there with ITP are mucosal bleeding, like the gums, the nosebleeds, and that happens because platelets form primary hemostasis and you get mucosa that's first to show the bleeding when it's low. And the petechiae, the non-blanching red spots, that comes from the capillary bleeding due to the absent platelet plugs. You know, the platelets aren't there, so you're just going to bleed. The low platelet count is really what you should be looking for ITP is the low platelets. And by the way, let me just say, it's best to just memorize this when you guys are in medical school going through your classes as opposed to like during dedicated period. If you ask me, the whole entire medical system is backwards. People theoretically should be able to pass step 1, 2, and 3 online and then just do 1 year, but whatever. What do I know? Typically for ITP, you might see a child with like a recent viral illness, and that's often acute or self-limited ITP. Also adult woman with chronic bruising. That could be like a chronic autoimmune ITP. And you have megakaryocytes increased on the bone marrow, and that's because the bone marrow compensates by producing more platelets. And so the labs in ITP, you'd expect low platelet counts, normal PT, APTT. The hemoglobin would be normal. The white blood cell count would be normal. The bone marrow, however, would be increased megakaryocytes. And so in children, the treatment is usually just observation. If it's mild to severe, then you use corticosteroids, usually to treat the inflammation. And if it's really severe, IVIG, anti-DIG, rituximab, splenectomy. But you should avoid NSAIDs and aspirin because that'll worsen the bleeding risk. This is reduced dermal collagen in this particular question, senile purpura. And senile just means like old age purpura, or I guess purpura, I should say. Tomato, tomato. All right, folks, the bottom line is recurrent non-traumatic purpura in elderly patients is often due to reduced dermal collagen support. All right, folks, look at all that stuff we just did there. Let me ask you, was this helpful? If it was or wasn't, then like or comment respectively and let me know how I can improve. My goal is to help you pass this silly exam and become amazing physicians. Remember and dedicated, take time for yourself. No thought is final. You can always reinvent yourself every single day. If you need to take a day to chill, it's fine. Tomorrow, get right back on it. We'll see you guys and have a wonderful rest of your day.